Hello, everybody. And now for this week's lecture, we're going to talk about panic, anxiety, obsessions, and their disorders. This is a pretty involved chapter. There are a lot of details, a lot of different disorders that we're going to be talking about, and probably the chapter that includes the disorders that have the highest prevalence rate. We probably know a lot of people that are anxious or have anxiety disorders. Maybe they have generalized anxiety disorder. Maybe they have a specific phobia. So fairly common disorders. All right, so let's get started. We're going to be talking about fear and anxiety. Historically, the distinction centered on whether the source of danger is obvious. Okay, so fear is something that it's right in front of you and you're fearful. That could be a grizzly bear, that could be, a roller coaster or something like that. Whereas anxiety is this anticipation. You can think to yourself, well, I'm anxious because I don't know if I'm out there camping and I might see a bear, right? That's anxiety. Fear is, no, I'm looking at that bear right now and it looks like to me he looks pretty hungry. So you need to get out of that situation. Both of these things can cause a physiological response that is pretty similar, and that's what we're going to be talking about in this chapter. So fear or panic can activate the fight or flight response. Right? You need to get out of that response. You're either going to fight or you're going to run for your life, the flight response. Okay, so fear and anxiety share the following. They share some cognitive components, they share some physiological components, and some behavioral components. And we'll talk about each one of these separately. So let's talk about anxiety real quick. A general feeling of apprehension about possible danger. Right? So it's not the danger is occurring. It's not the fear that is coming from the stimulus at this time. It's the anticipation of that stimulus. It's future oriented and does have cognitive, physiological, and behavioral components, which we'll talk about real quick, like right now. Okay, so the component, let's talk about cognitive and subjective component. For fear, it is I am in danger. That's the cognitive part. I am in danger. It's happening right now. Anxiety is I am worried about what might happen. Okay, so it's future oriented, just like we said. If we look at the physiological component, for fear, it's an increased heart rate, sweating. You can think of the sympathetic nervous system, the fight or flight response, all of the things that are around that. Okay? Blood is shunted away from the GI system to the muscles. Heart races, the sweaty palms, but you also, your like stomach pangs, right? Because the blood's being shunted away from it. All of these things are the physiological response. For anxiety, we're looking more at tension, chronic over-arousal, okay? And so I think you can already identify where we're going with some of these disorders, some of the anxiety disorders, right? Because the stimulus is not there. It doesn't have to be in front of the person for them to still be anxious about it. And so it's that tension. And here it specifically says chronic over-arousal. That chronicity is the big issue, especially with something like generalized anxiety disorder. They just never feel comfortable. They always feel on edge. Is the stimulus right there in front of them? No. But it's the anxiety, it's the anticipation that something bad could happen. Okay. Now, what about behavioral? So under fear, we have desire to escape or run. And then under anxiety, the general avoidance. So again, if you don't like speaking in front of people, you are going to avoid speaking in front of people. The stimulus is not currently there. You're going to have a tension and over-arousal, even about the opportunity. You take a class and you think to yourself, oh, I just know that the faculty member is going to ask me to speak in front of the class. So that is a source of tension, right? On page 175, the adaptive value of anxiety. I'm going to read this. It says, the adaptive value of anxiety may be that it helps us plan and prepare for a possible threat. In mild to moderate degrees, anxiety actually enhances learning and performance. For example, a mild amount of anxiety about how you are going to do on your next exam or in your next tennis match can actually be helpful. But although anxiety is often adaptive in mild or moderate degrees, it is maladaptive when it becomes chronic and severe, as we see in people diagnosed with anxiety disorders. Okay, so just like all of the disorders that we talk about, they're on a continuum, and the real detrimental factor to these disorders is when they become chronic, right? And it lasts over a long period of time. It's just like any stress. There is good stress. We talked about this in the previous chapter. And so there's an optimal amount of stress that's actually good for us. So, and anxiety, you can think about it in a similar manner. Okay, so an overview. We're going to talk about specific phobias, social phobias, panic disorder, agoraphobia, and then GAD. Excuse me. Generalized anxiety disorder. All of these share an unrealistic or irrational fear. They cause distress, and it can be disabling. These are individuals, you have people suffering from agoraphobia that won't leave their house, right? So let's begin with phobias. They are strong and persistent fear of a recognized object, okay, or it could be an animal, it could be all kinds of different things, triggered by a specific object or situation, and avoidance of trigger is the cardinal characteristic. So again, this is the big thing, that it becomes debilitating for people because they have a fear of spiders, okay, and a lot of people have a fear of spiders. That might even be common, right, to have a fear of spiders or snakes. But for most people, you're careful about it. You go about your day. You don't think about it most times unless you're out in, hiking or something like that. But these individuals, they're constantly worried about spiders. And a spider could be anywhere. How do I know? How do I know there's not spiders in my room or spiders in my bed, right? And so there's a constant avoidance of certain situations. And you can imagine that this can get to a severity that they, again, kind of lock themselves in, and they don't go out and experience anything because they're too fearful. There's several specific phobias in the DSM-5, like animal phobias, natural environment, blood injection injuries, situational, and then others like choking or open spaces and things like that. So these are the primary subtypes. You can see how there could be hundreds of these under animals and natural environments, and so there's a lot of them. These are just the major categories. Lifetime prevalence for these is about 12%. That's pretty high, 12%. We're gonna see other disorders that are like at 1 and 2%. Okay, more common in women than men. Age of onset varies widely, and that's interesting too, because a lot of your disorders, we kind of categorize them within an age range, but these, it varies. It's kind of all over the place. Psychological causes. According to the psychoanalytic viewpoint, they're looking at repressed impulses from the id. Remember, the id, the ego, the superego. The id and the superego are fighting, and the ego has to try to make things right. You have your defense mechanisms and all that kind of stuff built into it. But that's what the psychoanalyst would be looking at. But there's also a learned behavior component that's possible, and that makes sense. Passed down from generation to generation, you see other people in your family who are extremely fearful of a situation, extremely fearful of an animal of some sort, and you're going to take on those same character traits. And this just elaborates a little bit more on that learned behavior. The examples that I was just gave you are vicarious, right? Observational, person to person. But there could be individual differences also, like risk factors, protective factors. What if you were an individual who was mauled by a dog when you were a little child, and now you are very, very scared, okay, of dogs, and maybe you then develop a phobia for dogs. Okay, and then evolutionary preparedness. It's pretty fascinating that worldwide, most people are scared of snakes. There's just something about that. That's something, the way that we're wired, that people are fearful of snakes. So that's a good example of a preparedness of that stimulus. So biological causal factors, you're looking at genetics, and then you look at temperament. Okay, not much to go in there, but we'll keep it pretty basic on that one. But there's a genetic component. There's also a temperament component. Okay, so how would we treat these specific phobias? There's exposure therapy, which is you could use like systematic desensitization. You could use flooding. Just depends on the stimulus. Through systematic desensitization, the nice thing with that is that you train the individual with relaxation techniques so that they understand their relaxation response, so that when they're confronted with that stimulus again, they can settle themselves. They can bring down their that fight or flight response using the parasympathetic nervous system, etc. There's also participant modeling. So that would be an individual who would actually be holding the spider or holding the snake, and then showing the individual that, see, there's no problem. They're kind creatures. They don't attack you and that kind of thing. Virtual reality is kind of the same way, where you can interact with the stimulus, but in a virtual environment, so it's not as threatening. And then there is medication as well. But not a lot of medications are effective for the specific phobias. The D-cycloserine that you see down there, that's an agonist for NMDA, and so it's going to be an anti-anxiety medication. But as it says, it's not very effective alone. You need something else like exposure therapy or something. Okay. What about social phobia? So we went over the specific phobias, now social phobia. Disabling fears of one or more specific social situations. Fear of exposure to scrutiny and negative evaluation of others. Some subcategories could be performance, could be non-performance. So I hear this from my students all the time, that their biggest fear is speaking in front of the class. Okay. And so again, very, very common. Social phobia, like I mentioned to you, a lot of the disorders that we talk about in this lecture are common, right? Again, lifetime prevalence, 12%, more common in women than men. Typically begin during adolescence or early adulthood, and many have a comorbid disorder, such as other anxiety disorders or depression. So we'll be going over this term a couple more times. Comorbid or comorbidity, that just means that if one has a social phobia, it's highly likely that they might also have another type of anxiety disorder, or they have a substance abuse disorder, okay? Or in this case here, they talk about depression. Okay. Causal factors here: learned behavior, vicarious. We talked about that. Evolutionary factors: ridiculed by superiors. Perceptions of uncontrollability and unpredictability. And then cognitive biases, belief that others negatively evaluate them. And this is definitely true. I love the last one the best, because in all of my classes, I can't remember ever there being a time in which I had a student present in front of the class in which they were ridiculed, in which there was any kind of negative evaluation. As an instructor, I prepare the class so that that's not going to happen. But does that take away the fear or the anxiety of speaking in front of the class? No. they still have that same, because it's this cognitive, way of thinking that they just can't let go of. All right. Again, we see temperament and we see genetics. Are these people, introverts, and therefore they develop a social phobia? That's going to be a temperament issue. And genetics, we know this because of twin studies. So if we see that there's a higher likelihood between the twins, then we know that there's genetics playing a part. So treatment: cognitive behavioral therapy. The medication, again, D-cycloserine, but again, it's probably not going to be a cure-all. It has to be accompanied with something, and that something would be this cognitive behavioral therapy, oftentimes known as CBT. It deals with cognitive restructuring and control automatic thoughts. So think about this. Cognitive restructuring. If in your mind you're saying, I have to give this presentation in front of the class, I know that I'm going to get laughed at, or I know I'm going to miss something and people are going to snicker. I know that there's going to be somebody who kind of rolls their eyes and because they think that I don't know my material well enough. Okay, those are all your cognitions. You have no idea if that's the real reason why the person rolled their eyes. Maybe they saw maybe somebody texted them and they just glanced over on their phone, they read something, they start laughing. They're not laughing at you. They're laughing at something else. But that's what you've built up in your cognitive thinking. Okay? So that has to be restructured. And also the automatic thoughts. I'm not going to do very well. I just know I'm not going to do very well. Right? That's an automatic thought, and we have to restructure it. Okay, what about panic disorder? So occurrence of panic attacks seem to come out of the blue. They're often recurrent. There is this anxiety, right? Worry about additional attacks. When am I going to have the next one? And think about this. It's like, well, I'm going to a wedding, or I'm going to fly back east, and I know that's when I'm going to have the panic attack. Imagine what would happen if I have a panic attack and I'm on the plane and there's nothing I can do, right? Ruminating thoughts. There you go. Perfect example. Must be abrupt onset of 4 out of the 13 symptoms. Those symptoms are in your book that you can look at. I even put the page number on there for you on 188. Agoraphobia is the fear of crowded places. And this is one on page 189 that you can read more up on. But this agoraphobia often causes the panic disorder. All right, now here we see this drop, right? 12% in the last two. Now we're looking at 4.7%, twice as prevalent in women. Typically begins in 20s to 40s. As I mentioned to you before, most of these have an age range for onset and follows chronic and disabling course. Now that's the big negative here with panic disorders. Chronic and disabling course, because what happens is that it can become worse and worse and worse to the point where it becomes debilitating, and then the individual cannot have a normal life, interaction with their family, occupation, etc. All right, and here's that term again, comorbidity. 83% of people with panic disorder have at least one comorbid disorder. That's really high. 83%. 83% of people who have a panic disorder also have to deal with other anxiety or substance abuse disorders. 50 to 70% will experience serious depression at some point in their lives, and the suicide rate is high. So that's also really high, 50 to 70%. All right. The first attack for panic disorder frequently follows feelings of distress or highly stressful life circumstance, and many adults who experience a single panic attack do not develop panic disorder, but it's in the back of their minds, right? Could this happen again? The first one completely happened out of nowhere and seemed like it happened for no reason whatsoever. So why would I assume that I would know when the next one's going to happen? It might just come out of nowhere as well. Okay? And so they keep ruminating about that. On a biological level, genetics, there's a component there. Panic in the brain, we're seeing activation of the amygdala, that's the fear network, the para-aqueductal gray, and higher cortical centers also. Here's where we'll be talking about the cerebral cortex and anterior portions of the cerebral cortex. Biochemical abnormalities, you have noradrenergic and serotonergic systems involved, and low levels of GABA. Remember, or you might not have known this in this class, but GABA is the most prevalent inhibitory neurotransmitter. So what it's doing is it's settling us down. It's inhibiting the response. So if you thought about neurons in your brain and they're all firing, GABA can help a lot of those fire less frequently. Okay. If you're having these ruminating thoughts and you can't think of anything else except for these thoughts, that GABA can help reduce the activity of those neurons. Okay. If you think about it in that aspect. So having low levels of GABA would make sense. You have less of an ability to settle your mind. You have a less of ability to decrease the firing of those neurons. Okay. Psychological factors. We're going to go into more detail on this. Cognitive theory of panic, and this is going to be figure 6.2. Oh, actually, I'm going to hold off on that one because I have another slide that will discuss that. Comprehensive learning theory of panic disorder. Here, what we're talking about is like with classical conditioning, and the CS and the UCS and the CR, the conditioned stimulus, conditioned response kind of a thing. This is just a learning approach. If two things happen or occur within a certain amount of time, then you start anticipating that stimulus. It's kind of like the stimuli replace one another. Okay, so I guess I can give you the example of like thunder and lightning. So if thunder causes you to tremble because thunder is really loud, makes everything shake, right? So every time you hear thunder, you're anxious, right? Or you get under something or whatever. And then you have now lightning. Well, lightning is always paired with thunder, and then thunder makes you anxious. So now you have the pairing of lightning and thunder over and over and over. Now, guess what? Lightning can replace thunder, and lightning itself can now cause that same fear or anxiety. Okay. So think about this in this regard with a panic disorder and let's say your fear of spiders. So your fear of spider came from a spider biting you. Again, lots of us get bit by insects and we don't develop a panic disorder, right? But for whatever reason, this individual gets bit by a spider, and it was severe. Maybe they were hospitalized or something like that. And so now they're like, well, I was bit in my bed in that room, right? So the room and the spider are now paired. So guess what? Now the room itself can cause that same fear. And that's what we're talking about with the learning theory. What about anxiety sensitivity and perceived control? Anxiety sensitivity is a trait-like belief that certain bodily symptoms may have harmful consequences, or more prone to developing panic attacks and perhaps panic disorder. Okay? So a trait-like belief that certain bodily symptoms may have harmful consequences. So that's definitely going to be a causal factor. Safety behaviors thought to alleviate panic attack. Here, these individuals, they're being told, they'll go to all the different doctors, and every doctor will let them know that when you're having a panic attack, you will not die. But during the panic attack, these people feel as though this is it. I'm done. This is my last minute on Earth here. But their physiology doesn't match somebody who is actually dying. Okay, their heart is racing. It's not skipping. It's not, blood pressure is going up, but it's not, to that extreme level, or is not fading away, which would, actually kill you. So what they have to learn are the safety behaviors, right? They have to realize that what's happening right now, it's okay. I can calm myself down. I'm not dying. I am just really anxious right now. Let me relax a little bit, or use diaphragmatic breathing or something like that to help me out of this. And then cognitive biases. This is an interesting one here too, because these people often are drawn to threatening information. What does that mean? Well, they read, they Google everything. They say, oh, I was feeling my heart rate the other day and it skipped a beat. Okay, so they spend the next 3 hours on the computer trying to figure out what's wrong with them because their heartbeat skipped. And they look up all these different sites, and it's like, yep, see, I have this and this and this, and I knew it. It's not a good thing, right? And so the panic disorder just keeps increasing in severity. And here's that panic cycle that I told you about. So trigger stimulus right at the very top. Okay, perceived threat. That goes to apprehension or worry about having a panic attack. That goes to the body sensations, right? Which is the trigger stimulus. And then that goes to the interpretation of sensations as catastrophic, and then that goes back up to perceived threat. Okay. So according to the cognitive model of panic, if a person then catastrophizes about the meaning of his or her bodily sensations, which is at the very bottom there, this will raise the level of perceived threat, thus creating more apprehension and worry, as well as more physical symptoms, which fuel further catastrophic thoughts. Okay, and guess what? It becomes a cycle, and it's really, really hard to get out of that cycle. Okay, treatments here, behavioral treatments, prolonged exposure, again, talked about that, cognitive behavioral treatments, so CBT, we talked about that, and medication. And here we're looking at the anxiolytics or the antidepressants, and SSRIs are just a type of antidepressant. All right, moving on to generalized anxiety disorder. This is chronic or excessive worry about multiple events and activities. See, it's not being put into the category of a specific phobia because it's not a specific object. It's not a social phobia because it's not just when you're speaking in front of a group. It's not put into the panic attacks. It's just this underlying worry about multiple events or activities throughout the day. Occurs more days than not for 6 months and accompanied by at least 3 of the 6 symptoms. And sure those are also listed in your book on page 198. All right, 3% of the population. Again, much lower, right? Lifetime prevalence is 5.7, twice as common in women, and 60 to 80% report having been anxious nearly all their lives. Okay, that's pretty high. Comorbidity again here with GAD. Yep, other anxiety disorders and mood disorders, and they experience occasional panic attacks. So GAD, generalized anxiety disorder, these individuals that suffer from that can also have incidences of other anxiety disorders or mood disorders. With mood disorders, we're talking about depression or manic disorders, and then experience occasional panic attacks. Psychological factors, the psychoanalytic viewpoint, again, conflict between the ego and the id. We talked about that. History of uncontrollability and unpredictability events in the past. Little control over their environment. Negative consequences of worry, and cognitive biases for threatening information. So we talked about the threatening information. They might seek that out. Negative consequences, little control. And, the one here with history of uncontrollability and little control over their environment, a lot of that is learned behavior as well. A lot of that is upbringing, right? A lot of that is how your parents dealt with certain situations, and you watching your parents and how they dealt with certain things. And if your dad is the kind of person that says, well, I have the worst luck in the world, nothing good ever happens with me, I just, everything is horrible and terrible, and so you grow up knowing that you're not in control of anything. You can't predict anything, right? And so you can see how that would cause this underlying anxiety and discomfort all the time. And remember that stat that we just gave, up to 80% of the people when asked, they felt, I've always felt this way. So even when they were a little kid, they may have had this underlying anxiety. So again, genetics play a part, low GABA plays a part, and we talked about why that would be. And then the one here at the bottom, you have corticotropin releasing hormone. Just in that regard, think of cortisol. Cortisol is that hormone that initially it's a good thing. It helps us break down glucose so we can do that fight or flight if we have that fear stimulus right in front of us. But if we are unable to control it, it can be at an increased level and then just stay at that level, and then it has all kinds of negative effects on us. Treatments: anxiolytic drugs, antidepressants, buspirone, which is an anxiolytic drug, and then CBT, cognitive behavioral therapy. So we see a very similar pattern with these anxiety disorders in the way that they're treated. Okay, and then we keep going. I told you there were many disorders in this chapter. So here we have OCD. Most people are familiar with this: occurrence of unwanted and intrusive obsessive or distressing images. Okay, and then usually accompanied by compulsive behaviors. So the interesting thing here is that you have to know that an obsession is a thought, a compulsion is an act. So the thought is, I'm dirty. The compulsion is, I need to shower, I need to wash my hands. Okay. So some of these obsessions could be contamination, fear of harming oneself or others, needs for symmetry, sexual, religion, aggression. And then the compulsions, if you're fearful of contamination, it's always cleaning. Right? You might be a checker. They actually use that term as a checker. Some kids are this way where they select a number for whatever reason. they close their door, and then they check the knob on the door maybe 6 times. Click, 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 and then they'll go off and go to bed. But they have to check. Then they go into their bed, and then they have to check under their bed, make sure there's no fearful things under their bed, and they check that 6 times. Okay. So definitely the compulsions can be repeating, a lot of order here, and a lot of counting. Okay. 1-year prevalence, very low, 1%. Lifetime prevalence, 2 to 3. Higher rates among divorced and unemployed individuals. And OCD affects both genders about equally. So that's the first time we've seen that, right? All of the other disorders had a higher prevalence for females than males. This one's equal. Typically begins in adolescence or early adulthood. All right, yep, and it also has a comorbidity factor. Frequently co-occurs with other anxiety disorders and mood disorders. Depression occurs in 80%. Again, that's really high. Psychological factors. OCD is a learned behavior, and we talked about the learned behavior. You can read more about Mohrer's there to process theory, but I kind of explained that in the way of classical conditioning and so on. Preparedness, the evolutionary adaptive nature of fear and anxiety. We talked about that. And then cognitive attempts to suppress thoughts cause an increase. So you have to remember that with this one, it's not just the ruminating thoughts, it's the acting out that follows the ruminating thoughts. And the acting out part is the big rewarding component to this whole cycle. You wash your hands because you believe that it is effective in suppressing the obsession of my hands are dirty. So every time you have the obsession, you need to wash your hands. Why do you wash your hands? Because in your mind, that's fixing your hands being dirty. It's fixing the obsession. And so that becomes rewarded, and it's a very strong, cycle. We see genetics. We see the role of the basal ganglia. Now, it's interesting here. Basal ganglia has to do with motor systems. And that's why I put it in here, because just like I was saying, it's the action that follows the obsession that is key for this. It says the basal ganglia are in turn linked at the amygdala to the limbic system, which controls emotional behaviors. Findings from a good number of studies using PET scans have shown that people with OCD have abnormally high levels of activity in 2 parts of the frontal cortex. And then it goes on from there. But the basal ganglia is that motor component. And then we have serotonin, which is a neurotransmitter. And in this case, it is probably going to be low levels of serotonin. So when you're talking antidepressants, when you're talking specifically SSRIs, which are selective serotonin reuptake inhibitors, these drugs are trying to increase serotonin. Treatments, exposure and response prevention, and medications that affect serotonin. Kind of just an elaboration of what we just said. Okay, look at here. E-lecture topic item. So here is this information for you. Please fill that out, complete in detail, and then submit it with your discussion thread. Okay, there's only a couple more that we have left here. Body dysmorphic disorder. These individuals are obsessed with perceived or imagined flaw in their appearance, causes clinically significant distress, and may focus on any body part. General population, prevalence here 1 to 2%. People with depression, though, the prevalence goes up much, much higher at 8%. Affects both genders equally, so that's the same as OCD, and typically begins in adolescence. The relationship here between OCD and eating disorders, or which are related to the body dysmorphic. You look at OCD, look normal. These individuals look normal, but they're obsessed and distressed about some aspect of their appearance. Anorexia nervosa, they look emaciated and generally satisfied with this aspect of appearance. Okay. For the anorexic, they look emaciated. You would think that they would know that, yeah, you don't look healthy, but they still believe that they need to lose more weight. Okay. Okay. So for BDD, again, antidepressants and CBT, because it's a lot based on those thought patterns that need to be restructured. What about hoarding disorder? These individuals acquire and fail to discard limited value possessions. They're disorganized in their living space, and it's very poor prognosis for treatment, or it's a poorer prognosis for treatment than OCD even. Okay, so it's very, very hard for these people to stop their hoarding. And then we have trichotillomania. Trichotillomania is the urge to pull out hair from any body location, preceded by tension and followed by pleasure, and causes clinically significant distress. So I put these last couple on here because they have been added to the overall category of anxiety disorders in the DSM-5. And so you could probably add the biological factors, the psychological factors, the treatments that we've already discussed. You could probably apply those also to these last couple here. And I believe that is it for this lecture. Thank you.